Okay, that's great. So I think we'll get started. So first of all, thank you very much for joining us today. I'm Clare Morrison. I'm Director of Engagement and Change at Healthcare Improvement Scotland. So before we get started properly, we'll take you through some general housekeeping for the session. So if you could mute your microphone and switch off your cameras, because that just helps in terms of the call quality. We will be using the chat function today, so please post any questions or comments into the chat. After each of our speakers, there'll be time to pose your questions and comments. And if we don't have time to get to all of your questions to the speakers, we'll produce a written Q&A to circulate after the event. If you experience any technical difficulties, please email us, which is his.mat@nhs.scot. We recognise that we regularly work in an emotive context, and there may be content today that includes accounts of personal experiences across alcohol and drugs, which may be triggering. So it's really important that we look after ourselves. So if at any point you need to take a break, then please feel free to do so. If you'd like to ask a question more privately, you can email us again, and perhaps someone will just pop that email address into the chat box. And as I said during the first few minutes, there is the poll, although the poll seems to not be working, currently available, just really in terms of understanding why you're joining us today. If the poll isn't working, then we'll move on from that. But thanks to everyone who did manage to participate in the poll. We'll move on to the next slide now, which is the agenda for today. So today's agenda will start with a presentation on the impact and implications of the MAT standards on pharmacy, particularly community pharmacy. Our second speakers are going to share their thoughts on aspects of the report that relate to responding to population needs. Following this, we'll have some time to ask any questions or share any reflections you may have on what you've heard from the first two speakers. We'll then take a short refreshment break at 11:45, and then our last speaker of the day is going to talk about how we move from the current substance use service provision to a future model of service delivery. Again, there'll be some time following that presentation and reflections on all of the presentations to ask any questions or share any thoughts about what's been covered. During any of the presentations or at any time, please do feel free to put any questions or comments into the chat. So we'll start with our first speaker of the day, and to welcome Adrian MacKenzie, who's Pharmacy Clinical Lead for MAT Standards here at Healthcare Improvement Scotland. Adrian's going to present a high-level summary of the recently published report by Healthcare Improvement Scotland into the impact and implications of the MAT standards on pharmacy, particularly community pharmacy. So please do use the chat function as he's presenting, and there'll also be that opportunity to ask questions at the end as well. So over to you, Adrian.
Thanks very much, Claire. And so, as I said, my name's Adrian MacKenzie, and I'm going to share with you some brief insights on work done by HIS in conjunction with stakeholders to review the impact and implications of the MAT standards on community pharmacy. Next slide, please. All right, okay. Just before I begin, I'd like to thank all those who were involved, who gave up their time to be interviewed and reviewed drafts of the report. Full report is available on the HIS website, and links will be put in the chat and sent out to everybody that registered. So quick outline of what I plan to cover. The background to the work, findings from our literature review and stakeholder interviews, outcomes of our cataloguing services work, our strategic findings, and lastly, key messages and changes needed. Next slide, please. Now, it's important to recognise that all sectors of pharmacy contribute to MAT standards delivery. Community pharmacy is the sector of pharmacy that has the greatest degree of engagement with people who access substance use services, and for that reason our report focused on community pharmacy services in Scotland. The findings of this report will now inform the design of a national improvement programme for MAT standards implementation. The recommendations report explored two main themes. First was understanding pharmacy services, so cataloguing arrangements for substance use services and identifying variants in those services. Second thing was around defining pharmacy services, so clarifying the expected role and capacity to deliver the MAT standards. And lastly, identifying the training, support, service and infrastructure developments that will be required, including any modifications of pharmaceutical services contracts. Next slide, please. So this graph is the single best reason I can give you why community pharmacy is a key healthcare profession to deliver improvements in the care of those impacted by substance use and deliver the MAT standards. Many of you may be familiar with the graph presented in front of you. So the orange line is drug-related death rates adjusted for age and standardized. Now that's plotted against the SIMD quintiles. And as you can see, as you change quintile to its less deprived neighbour, the death rate halves. The compounding effect of this is that you are 16 times more likely to have a drug-related death in our most deprived quintile than in the least deprived one. The blue bars show the number of pharmacies found in these quintiles. So as you can see, the location of pharmacies are primarily in our deprived communities. 55% of pharmacies in Scotland are found in the two most deprived quintiles, where most of our drug-related harm occurs. It is for this reason primarily that pharmacy has a key role around substance use. Next slide, please. So the first strand of our report consisted of a rapid literature scan and analysis of stakeholder interviews to explore potential facilitators and barriers to the delivery of MAT standards. From our analysis, three key themes emerged. First one was around knowledge and confidence. Most interviewees felt the principles of the MAT standards could be broadly applied to everybody who visits a pharmacy. We noted variance in levels of experience and working relationships across pharmacy teams due to a lack of training. Improved access to care records, e-prescribing and support for clinical decision-making were felt to improve levels of care if they were put in place. In terms of relationships and engagement, pharmacy is not always included in strategic and commissioning conversations. People using MAT valued the positive and trusted working relationship with pharmacy teams. However, some pharmacies, like the wider population and other health and social care services, can represent a sort of stigma. In terms of system support and structures, we found that families were not well represented in the literature. However, they expressed a view during an interview that they would like to help shape services. And given the right information and clear referral pathways, pharmacy teams can encourage people to access other interventions. Interviewees highlighted gaps in system communication for people around transfers of care. So, for example, from acute care or from prisons. Next slide, please. Our second strand gathered informal feedback from stakeholders who were involved in face-to-face service delivery, as well as those with living or lived experience as part of our routine data gathering. Stakeholders covered 6 areas, covering both urban and rural areas. And I just want to talk you through a summary of the key themes that came out as part of this part of the report. So in terms of location, distance to pharmacy, particularly in rural areas, was cited as a barrier to treatment, despite, as we've seen earlier, community pharmacies being well placed where the need is greatest. In terms of relationships, several stakeholders confirmed positive relationships with pharmacy teams, and some stakeholders, however, felt that pharmacy could be seen as a hub for targeting vulnerable people to sell their MAT or purchase illicit or diverted drugs. In terms of availability of services, there were limitations felt by some stakeholders in the interventions pharmacy teams can make. For example, due to a lack of communication channels and not having read and write access to health and social care records. Next slide, please. The third strand of our report was to understand pharmacy services to support those impacted by substance use. We identified inconsistencies in service delivery through differences in scope of service and levels of funding available to pay for services when we made comparisons between localities and board areas. We surveyed all 14 territorial boards and received responses from 12 of them to help us quantify this variation. So our findings were that most health boards have adopted a package of care model, delivering a package or bundle of care. These have replaced previous item of service payments and is in line with the Drug Death Task Force Change in Life report for a single once for Scotland package of care across all health boards. Every health board who responded had in place provision of harm reduction equipment, also known as injecting equipment, through some of their community pharmacies. And prior to rollout of the national holding of take-home naloxone for emergency use, most boards had this in place as a local negotiated service. Half the boards have a local negotiated service in place to distribute take-home naloxone across Scotland. No health boards at the time of our questionnaire reported having a service in place to test for bloodborne viruses. Respondents felt that payment mechanisms are complex and services were often funded from multiple sources, which was felt to be a challenge. All 12 health boards who responded have at least one specialist pharmacist in substance use. However, funding for many of these posts was temporary or fixed term, and vacancy rates were found to be higher than the pharmacy average. Next slide, please. Our fourth strand looked at the strategic environment community pharmacy operates within and a relationship with other stakeholders. These findings can be summarised into the 4 headings you see on the slide there. So in terms of needs assessment, it was not always evident that ADP planning and the board's pharmaceutical care services plan were linked to ensure substance use services are considered and plans to close any gaps are developed. In terms of system mapping, the recruitment and retention of pharmacy staff is an ongoing challenge linked with ensuring that all staff have the knowledge, skills and confidence to support people. Time constraints and premises were cited as a challenge in some pharmacies around service delivery. In terms of a vision for community pharmacy, pharmacy stakeholders had a clear vision of what could be delivered through community pharmacies currently and in the future. Stakeholders felt that pharmacies were located well geographically and had a long history of delivering public health interventions. In terms of consensus around Scotland, there was evidence that community pharmacy teams already play a key role in supporting people who use substances and can do more to deliver on the MAT standards. Pharmacy stakeholders must include people impacted by substance use as a priority group for polypharmacy review, as drug-related harm is a polypharmacy issue at its heart. This will also support engagement of this group with wider primary care services to improve physical and mental health needs. Next slide, please. Bring some of these changes together. we require a cross-governmental, cross-system joined-up approach, and some of these changes identified are outlined on the slide. Pharmacy stakeholders need to embed the principles of trauma-informed practice and reducing stigma within the pharmacy environment. This could be achieved by the existing person-centred approach to care delivered by most pharmacy teams. As has already been mentioned, there is a need to review needs assessments and ensure that these are undertaken for all pharmacy services, not just those for substance use, and ensure the processes involve pharmacy stakeholders and those with lived experience as part of their development. This will support all people who access community pharmacy services. All pharmacy stakeholders should embrace opportunities to progress the appropriate sharing of a person's information to avoid the risk of actual physical and mental health harms. And we call upon the Scottish Government to implement the actions described in its Achieving Excellence in Pharmaceutical Care strategy to modernise the contractual and planning framework for community pharmacy services, which will ensure alignment with the strategic intention of the National Drugs Mission. And there is a need to review the Orange Guidelines, which were last reviewed in 2017 and felt by many stakeholders to no longer reflect current practice. Next slide, please. So bringing this all together into my final slide, I'll summarise this into 5 key messages and 2 overriding messages. Pharmacy can play a greater role in reducing drug-related harm, support recovery, and improve outcomes. People who access substance use services recognise the value community pharmacy can bring in supporting recovery. Delivery is best driven locally by the alcohol and drug partnerships, collaborating with local stakeholders like directors of pharmacy to support chief officers in their accountability for delivery at a local level. And at a national level, integration and alignment across Scottish Government directorates is essential alongside reducing the complex and often multiple funding streams. Key enablers to facilitate change are the inclusion of pharmacy in local service planning processes, digital health developments to support clinical communications, care planning, and multidisciplinary training. There are many examples of innovative service provision in areas of good practice driving successful MAT service delivery within community pharmacy settings, and these could benefit more communities if they were spread across Scotland. Lastly, the 2 overriding messages are: the one thing that pharmacy internally can action that will make the biggest difference is working to make people who use pharmacies feel welcome. As I already said, this can be achieved by focusing on person-centred care and the principles of what matters to me. And the one thing that the wider system can action that will make the biggest difference is to implement across Scotland the single package of care as outlined in the Changing Lives report. Thank you very much for your time, and I'll hand back to yourself, Claire.
Thank you very much, Adrian, for that. We'll come back to you for some questions, but first of all, we're going to move on to our second speakers. So I'd like to welcome Tony McDavitt, who's the Director of Pharmacy at NHS Shetland and also the Interim Depute Chief Officer for Shetland HSCP, and also Chris Miller, who's the Chief Pharmacist for Primary Care in NHS Lanarkshire. So they're going to share their thoughts on aspects of the report that relate to strategic planning, commissioning and service development to respond to population needs. As I said before, please do use the chat function as they're presenting, but we will come to questions at the end of our first 2 presentations. So over to you both. Thank you.
Thank you, Claire, and thank you, Adrian, and thanks for this opportunity to speak today, both a Director of Pharmacy capacity, but also the Deputy Chief Officer role as well. I think it's important to always bring ourselves back, as Adrian did, to why this work is so important and realise some of the success we've had in Scotland over the last few years, that we've seen a reduction in drug-related deaths and harm related to substance misuse, and just really emphasise the point that drug-related deaths are preventable deaths. We have strategies in place that we need to maximise as best as possible to make them available to as much people who would be affected throughout the community, where community pharmacy plays an important part of that wider harm reduction ecosystem. The reducing deaths and improving lives conceptual model at the side of this slide is really important. We have to make several interventions across the spectrum of how people maybe are joining drug use or substance misuse across Scotland, but also then where we place our opportunities for intervention across the system as effectively as possible, and how we know that that effect has been realised. Pharmacies have worked well and innovated well. I've seen that both locally in Shetland and in Orkney, and we've still got a bit to do in this space to mature that clinical capability, the package of care that Adrian's realised in the report helps highlight, and realise the value we can get from it. And we need to maximise some of the frameworks we've got in place, including funding, which I'll go on to a bit later. So if we can have the next slide, please. So as a director of pharmacy, or in line with the chief pharmacist responsibilities I have for the health board, it's my role to oversee how the MAP programme is governed in community pharmacy and how it's provided. Together we support an area, the Alcohol and Drug Partnership locally, to commission the appropriate service based on service need and against the available funding we have for the need we've identified. This involves me, especially in chief officer role, spending a lot of time with our community mental health teams and our substance misuse teams to understand how we can better realise the value of the community pharmacy input, but also how we plug them into how we plan that wider substance misuse service, and not see them purely as a collection point or supply, but as a viable platform for harm reduction and improving the lives of these individuals who are affected by substance misuse and are most at risk of drug-related deaths. We've done that through a series of work with having really consistent and effective community pharmacists who are both prescribers, and two of our main community pharmacies who provide this, to align other services and other inputs that they can provide to the individuals who have the poorest health outcomes in our communities. There's broader social benefits to realise from this, and recognition for me as Director of Pharmacy that these services are really well placed in communities for individuals to access, and they have developed extremely strong relationships with people who otherwise don't come into contact with traditional health services. And it's placed that responsibility across us and helped us with a local conversation about how we effectively commission against the budget available. So it's very important for us as Directors of Pharmacy and Chief Pharmacists to consider these. Next slide, please. This is a quick slide overviewing the value of community pharmacy. Certainly the value we recognise locally in Shetland, that delivering care close to people is an important aspect of delivering across the remote and rural community. It's difficult to access across large geographies, but we've got a community pharmacy network because we've needs assessed that are in the right locations across Shetland to make sure that those people with needs are having those met. Provides a flexible and viable operating model. We can commission, we can contract, and we can package up ways of working and care for harm reduction as well as for opiate substitution therapy that suits our community pharmacy contractors locally, but is also supported by central funding, externally and commissioned through ADP. Importantly, they provide continuity care or care continuity to people with complex health needs and very poor health outcomes. And we know the value of continuity of care. We need to recognise what value that the community pharmacy network provides to those individuals. As well as that, it ensures people have safe and effective access to opiate substitution therapy, and it provides that broad harm reduction platform for locally enhanced services. And I've heard certainly through other areas where there's been huge improvements in access to that and really important innovations over the last couple of years. Next slide, please. I think just coming back to the key point, why are we doing this? That the reduction in drug-related deaths is important, but also understanding the role of community pharmacy and the role of OST in drug-related deaths, and how we've had a series of reports commissioned thanks to the excellent work that's been going on across Scotland with lots of different stakeholders and the task forces that have provided us some assurance that it is still the right model. There are strong evidence to support the continued use of this across Scotland, and continued support of both the harm reduction packages and opiate substitution therapy from community pharmacies. I think more importantly now, as a system, we have greater intelligence, and I certainly have greater intelligence to understand how our services provided in Shetland. It's really important for us all to take time to understand where we're performing across our different areas, using some of the dashboards that have been commissioned to Public Health Scotland. Next slide, please. So reduction in harmful behaviours, this is taken from the radar board, the dashboard, and it's helpful to see where we've had a change in performance over time, and where we're maybe needing to do some additional work. That is a very high level view of this, but OST and that continuity care provided by pharmacies is making a difference. It's certainly part of any analysis or understanding we try to take from any significant adverse events or any reviews of any admissions we have in our small system in Shetland for drug related deaths or for substance misuse patients, where we try to get under what could we do differently to avoid that admission or prevent it. And we've seen a steady decline in drug related harms attending in Scotland across that period and even locally. Next slide. I think this is a key area. I appreciate this slide's quite light, but the importance of accessibility and trust and improving patient engagement for community pharmacies is crucial here. Often it's difficult to receive patient feedback and lived experience, especially from individuals who are using our services. Where we have done it effectively has really helped us shape what the service looks like. And this was particularly relevant during COVID times, where we moved to a slightly different model of delivery. And we're starting to normalise back to where we were pre-COVID, but trying to retain some of the benefits we had from that service. Benefits not only in a service provider context, but benefits in what it felt like to use services when there was less need to attend, and how we had a different approach to risk stratification for reducing the burden of the community pharmacy service overall, whilst protecting the community pharmacies during that change too. We've had positive outcomes and been able to see that within our local service. It's important that we just keep that methodology in place of continuing to speak to our service users to understand their experience. Next slide, please. I think more broadly, this is taken from a study that was released in April 2024. We can see that there's a non-equal distribution of opiate misuse or opiate dependence, across Scotland. And this was helpfully done by Bristol University. It shows that we need to consider needs and needs-aligned commissioning, but also needs-aligned funding in the future, where we have this difference in prevalence across different areas. And that should support our system, our infrastructure, to have the right resource available, to be in the right place, to provide the right types of interventions, to support them, to reduce future healthcare costs, to reduce the need for these individuals to access more healthcare in the future, and to support them to have better health outcomes overall. And there's more opportunities where there is more funding aligned with needs to implement more innovations, to understand what might work, and to go through programmes of test and change as well. And next slide. I've used this graph to highlight some of the differences in funding, and I've used the islands in particular here, being a remote and rural director of pharmacy and working in Shetland, where the population of prevalent opiate dependence, people with opiate dependence, is higher in Shetland, actually have the lowest share of funding, which makes it much more difficult in Shetland to then commission services against need. With this increased activity across Scotland of trying to understand where our need is, and hopefully then using that to inform how we commission in the future and create resource for commissioning, will be really important. And that's something I'll take away with my Director of Pharmacy and also Chief Officer role, to make sure that we're having those conversations in strategic spaces and beyond the health board. And the report is really helpful at highlighting the benefits and some of the work plan that we need to put in place to do that across Scotland over the next 2 years. Next slide, please. So integrating pharmacy across the substance misuse, it's really important that we recognise that pharmacy is not everything that's in that space, that is part of a wider ecosystem, but we have weaknesses in how we've plugged it in locally and nationally, and how we have discussions across different stakeholders from government to commissioners, and that I think will improve over time. There's also an important role here for pharmacy as a general use service, that it's not just about substance misuse, but they can also undertake different risk mitigation activities, recognising that those with substance or opiate dependency have higher risk of poorer outcomes in the longer term, and that commissioning services to address some of those poor outcomes, thinking that an ageing population will have increased risk of cardiovascular disease. There's lots of opportunity for innovation in the future that's not just aligned to MAT, but recognising that the individuals receiving MAT aligned services will have wider health needs that we can address through community pharmacy. I think the last point on this slide, that the strong examples of effective ways of working throughout Scotland, and going back to Adrian's point, sharing to scale is really key here, and Chris will go into that when he joins after this. Next slide, please. So for me, the key take-homes are that maximising community pharmacy value as a provider MAT is a priority for ADPs, directors of pharmacy and chief officers. Community pharmacy provided MAT is an essential service and should be commissioned as core and commissioned with our substance misuse services. MAT will continue to play a significant role across the community pharmacy network in Scotland, and we have no alternative, and we should maximise that wider generalist capability that we've got in the community pharmacy network to complement MAT. We need to develop better ways of getting user and feedback to design the services and inform what we're doing in the future. And others in improved health outcomes realised through these services, thanks to some of the reports and analysis being provided in the past. Inequity in funding throughout Scotland, not aligned to need, continues to drive some structural inequity across our infrastructure, and we need to address that separately too. I think consistency across Scotland on the previous reports in this impact report is a consideration we'll make, but we'll use the strength of our networks, both the community pharmacy network and the group that Chris is chair of, to be able to drive some of that change as well. Thanks. I'll hand over to Clare.
I think you can hand straight to Chris.
Yeah, thanks very much, Claire. So hi everybody, my name's Chris Miller. I'm the Chief Pharmacist for Primary Care here in NHS Lanarkshire. And as Tony just alluded to, I'm also the chair of the Primary Care Community Pharmacy Group, which is the reason I've been asked to speak here today. And it's fantastic to actually see quite a few members of the group on the call as well. Can I have the next slide, please, Kyle? Thank you very much. So I'll open up just by outlining a wee bit about what the PCC PG group is for, because I know that some of you on the call won't have heard of us and won't be aware of what we do. So we are a national pharmacy sector working group that supports the directors of pharmacy, and we do that alongside the other two sector groups, which are NAPS, who represent the acute sector pharmacy, and SPA, that represent general practice pharmacy. Our group's got representation from all health boards across Scotland, and it will be attended by someone with a remit to support community pharmacy in your health board. We've also got membership from Public Health Scotland, NES, National Procurement too, so we've got a really good depth of experience, and we've got a good reach across the community pharmacy network as well. So as I said, our job's to advise DOPs on matters relating to community pharmacy, but also to provide advice to our own individual health boards, and to provide some national leadership by working as a collective to enhance pharmaceutical care of patients via community pharmacy. We as a group have been involved with the MAT standards work right from the beginning, actually. We regularly engage with Adrian and the Scottish specialists in substance misuse group, the SPISMS group. And again, it's great to see quite a few of you on the call today as well. And we mainly focus with that group when we're looking specifically at the role that community pharmacy play in recovery pathways. And over the last couple of years, we've co-authored the recommendation to the Scottish Government to move towards the package of care model for medication-assisted treatment. We've worked on developing supply of naloxone, as Adrian touched on as well, through community pharmacies across Scotland. And we've latterly fed into the consensus statement and best practice that you'll see in the appendices to the impact report that Adrian and the team at his have recently published too. Can I have the next slide, please? So when Adrian asked me to speak today, one of the things we wanted to explore is the role that community pharmacies play in recovery and how we can better utilise the many commissioning bodies available to support patients. I know that quite a few of you on the call will be in a position to commission services through your roles, either in alcohol and drug partnerships or in health and social care partnership roles as well. So I think for me, being able to open up these discussions with you all is very, very important. For those of you, and I apologise to the community pharmacists on the call, but I know that quite a lot of you won't be too familiar with community pharmacy services themselves. So I just wanted to quickly provide a wee bit of oversight around the community pharmacy contract, how services are implemented and governed. So there's just over 1,200 pharmacies in Scotland. I think Adrian did a very good job of outlining the location and the ease of access to services is one of the network's greatest strengths. And in Scotland, access to the Health Board's pharmaceutical list is controlled by strict legislation. And that means that somebody who's looking to open a new pharmacy must apply to the Health Board and go through quite a lengthy process of outlining why the new premises are both necessary and desirable to meet the needs of the local population. These controls are really important to maintain that strong network across the country, but it does unfortunately mean there are areas both of over and underserved by pharmacy. And again, that's where that close working between boards, HSCPs and the other statutory bodies becomes vital to make sure that we've got that right patient access to services. Adrian touched on this earlier on. Each health board should have a pharmaceutical care services plan published. And the plan will detail the pharmacy offering in the board, along with any detail on the additional enhanced services being undertaken. And it'll also identify unmet population health needs. So if you look at a board's pharmaceutical care services plan, it will usually start off by presenting the core elements of the contract, and then it'll move on to the locally negotiated elements. The core contract's actually negotiated nationally between Community Pharmacy Scotland and the Scottish Government. And that contains the elements that you'll all be familiar with: dispensing medication supply, medicines advice and treatment of minor ailments. It also goes on to describe some of the public health services that you might not be aware of. Smoking cessation and sexual health services are particularly of interest to anybody who's involved in treatment of patients with substance use issues as well. And the important task that we all have at the strategic level is to ensure that patients and other professionals are aware of these services, and I think how to refer and when to refer patients from community pharmacy and to community pharmacy. So again, if you have a remit around population healthcare in your board, I would urge you to get in contact with your local community pharmacy lead, see how we can start to make some of these links at a board level. The next part of the services plan is probably area of greatest interest to people on this call, and that's the locally enhanced services, which again Adrian touched on earlier on. So these services are not contained in the national core contract, but they're negotiated at a health board or HSCP level and are commissioned in response to a local need. Most common examples of enhanced services: supervised administration, injecting equipment provision and naloxone supply. But we have had instances of bloodborne virus testing and COPD screening undertaken through community pharmacy as well. And I think for me, the most striking thing about enhanced services when you look across Scotland is that variation in the number of services provided in each board. And also the variation in how services are delivered, and again touching on Tony's point, how these services are remunerated. So my colleagues are very interested in exploring, and we'll continue to do that by collaborating with the various commissioning groups and ensuring that patients have timely access to quality services. So again, if anybody on the call today wants to know more about the local enhanced services, please contact your board lead or myself, and I'll be more than happy to pick that up with you. Can I have the next slide, please? This slide actually comes from his report on community pharmacy services, and I thought it'd be worthwhile including it here, as it illustrates pretty well some of the challenges that we face in ensuring good patient care in community pharmacy. Community pharmacy is not alone, obviously, in the health service in being extremely busy, and I know that everybody out there working in community pharmacy continually doing their best to care for patients in their community. But we have to recognise the complexity of the system that we're operating in, and how this can lead to some of the difficulties in standardising services across Scotland when we're trying to bring new services in. So again, if any of you on the call represent any of these groups that are on here today, let's use this as an opportunity to start opening that dialogue and working within the recommendations of the report around streamlining some of these processes. And I think my other plea, if you are in a position of influence in one of these groups, is not to forget community pharmacy when you're developing services. And I've been around quite a few of these tables for many years. And unfortunately, the voice of community pharmacy is maybe not always brought in right from the start of discussions. But as Adrian's report shows, community pharmacists are absolutely intrinsic to that effective system to support patients in recovery. Can I have the next slide, please? This slide just quickly summarises some of what I've been talking about up to now, just in terms of commissioning and that need for pharmacy to work together with ADPs, HSCPs, being assessed and then planned in at that strategic level across the country. It's only through that collaborative approach that we're going to get the maximum benefit from our services. The HIS report also makes very clear the need to measure the outcome data associated with services again, and something that's something that's very variable depending on what the service is and the locality that it's based in across the country. So we do need to make sure that we're all regularly capturing and measuring the outcomes from the services that we're providing. And can I have the next slide, please? So I'll just briefly leave you with this slide, and I know these have been touched on previously, but these are some of the highlights that I took from the HIS report. But there are also things that I've picked up on, during my time in the world of pharmacy as well. And these three areas are not part of contracted community pharmacy services, but I think we do all have to work together to get these elements right, because these elements underpin everything that we are trying to do in the health service, and particularly for this patient group as well. Having that strong connection to other local services, not just health services, but to social care, third sector agencies, is so important to community pharmacies. But it's also more important to have that mechanism to refer patients into these services. So again, this is something that we all need to consider, and we need to help strengthening those referral mechanisms. The importance of psychological intervention and trauma-informed care has been discussed earlier on, but even at a basic level, this can't be underestimated. This is something I'm actually exploring in my own board at the moment. We don't have a recognised training route for community pharmacy staff into psychological care, but it's so important in supporting patients day to day. And that final element just at the bottom of the slide, we're all familiar with, and we all wrestle with this every day. How do we make sure that our digital systems that we have are working correctly in the background to join all of these services up and just make our pathways a lot slicker and more effective? So that's a quick run through for me and some of the issues and the enablers that we have in commissioning community pharmacy services. And I think now we're moving on to the Q&A session, Claire. So thank you all very much for listening.
We are, and thank you so much to Chris and to Tony for those presentations. We are running a little bit over, but we've got time for a couple of questions. And if there are lots of questions, we will follow them up after. So first of all, can I ask if anyone would like to raise their hands if they have a question for any of our three speakers so far? And while people are thinking about raising their hands, I suppose I'll give you a couple of reflections from me. I suppose going back to Adrian's presentation, I think that really striking data showing the distribution of community pharmacies in the most deprived locations where most drug-related deaths occur, and therefore pharmacy's key role and the actions needed to expand pharmacy's role in reducing drug-related harms was really strong. And thinking about Tony and Chris's presentation, so for Tony, that importance of pharmacy accessibility in terms of delivering care close to people and continuity of care and that broader role in harm reduction, and Chris's point about not to forget community pharmacy in planning and commissioning services. and the enablers to make services work, like on that last slide, like the referral pathways and digital systems to join those pathways up. So lots of takeaway messages within that. And I was hoping in the time that I filled there, someone would have raised their hands with some questions, but no one's hand is up yet. If you're not comfortable coming on and speaking, then please do put your question in the chat box, and we'll take questions in that way instead. And I'll just give you a minute to think about if there's any questions that people want to raise. I can't believe in 100 people there's not a single question. Obviously, our speakers did such an excellent job of outlining all of the positives and all of the challenges as well, that there's no questions. Okay, so we are going to have a second section later for questions, so you can take any questions later on as well. But what we'll do just now is we will have a short break. This will be just short of 10 minutes, I think, so that we come back at 11:55. We're going to put another question up on the screen as a poll as well, if you could contribute any thoughts to this, and it's about topics for future webinars, and it would be great if you could respond to this. So in the meantime, many thanks for our 3 speakers so far, and we'll see you all again at 11:55. Thank you. Hello and welcome back, everybody. It's always slightly strange when you're the only one on camera because you don't actually know if people are back, but I'm going to hope that people are. So welcome back, and our final session, our final speaker for this session is Adam Osprey, who's the Policy and Development Pharmacist at Community Pharmacy Scotland. So Adam is going to talk about how we move from the current substance use service provision to a future model of service delivery. Please do, and thank you for the questions we've got so far in the chat box. Please do continue to put some in as Adam is presenting, and we will pick up all the questions at the end. So thank you very much for joining us, Adam, and over to you.
Thank you, Claire. And yeah, a big thank you as well to all the speakers that have come before me. So Chris, Tony and Adrian, they've done such a good job of their parts that I might actually for once come in on time on my allotted slot, but you can remind me of that when we are at 1:15 and somebody's trying to give me the signals digitally to cut off. So I suppose before I start, a wee bit of a forward on the MAT standards. I think I am just so pleased that we're seeing such progress with them, and what a wonderful thing to have come in Scotland from a position like ours of representing pharmacy owners out there who are commissioned to do work on behalf of the NHS to get such a clear, practical national steer on. This is what we're aiming for, and I'm a practical guy, so really, really helpful. So delighted to come here and help out today if I can. So I've been asked to speak about how we move from current service delivery to future. If we could move to the next slide, Kyle, that'd be grand. And I suppose the first question there is actually, what is the current and what we're aiming for? Now, problem there is we've got a mixed audience here, and how do you do a bit of inform and focus to what we actually do without boring to tears the folk that are actually doing it. So what I kind of landed on was starting with how I intend to end as well, around about, okay, in a nutshell, what is it that we do without going into the fine detail? Well, actually, as the guys have already intimated throughout their talks, community pharmacy every single day are already contributing to the national goal of delivering the MAT standards, and they've been doing that before the MAT standards even existed. We can make that so much better, though, is probably the bottom line. With the right resource and by working with one another. I think Chris's slide that he put up there that came from the report was really, really brought it home for me in terms of we yes, might be in the middle for this particular part of the work, but all the work that is for pharmacy teams anyway, unseen around about them that needs to happen to get to a place where there's direct service delivery is so complex, but we need to be there. We need to be there to be given the view of, okay, yes, this is ideally what needs to happen, but we need to pass it through the filter of what's achievable, what's doable, what other ideas can we bring to the table. So yeah, very much going for working together and inclusivity here. If you could move to the next slide, please, Kyle, that'd be great. So little bit first about Community Pharmacy Scotland, who we are, what we do, as others have done for their respective organisations. So Community Pharmacy Scotland is a membership organisation. We exist for community pharmacy owners. They're the ones who are our paying members, who pay for my salary, the office, all the rest of it. And our big job, very simply put, is the national negotiation of services with the Scottish Government and representing our members and everything that we do. There's a whole load that falls out of that, but at the end of the day, that's what we're here for. Now, you'll be thinking in your head, hold on a minute, Chris has just told us that the national stuff's done nationally, but these are local services we're talking about today, so why are you here? But we'll go into a wee bit of that detail in a little minute. The other roles that we carry out are in service design, so very much involved with a number of the people that are on the call, looking at actually what do these services, both for substance use support and for other services, what do they actually look like, what's possible in a community pharmacy, then doing a bit of the sort of early implementation and then ongoing development of services to make sure that they are meeting the needs of the people of Scotland. Bit dull, but if you're interested, our structure, to make sure it's all fresh, our structure is all made up of community pharmacy owners, and then there's an executive team like myself who are employed to carry out their wishes, and those guys are formed of a structure that is voted on and elected to really truly represent the voice of pharmacy owners across the country via election. So all very much formally the voice in Scotland. So again, I think Chris kind of said there's 1,243 pharmacies out there at the minute. I think all but one or two of them are members of ours, so we do speak. When we speak with their voice. And we do as well, though, have strong links into the pharmacy teams that are actually day-to-day delivering services. We've got great links in with our e-newsletters and events that we run, much like this one, to keep me up to date with what's happening nationally and locally. Next slide, please. Cool. A little bit more about the network. Again, Adrian, Tony and Chris have all done a stellar job of describing how pharmacies actually come to be and how they're distributed perfectly. I'll not go into terribly much detail. I've got the exact number there. Our relationship with the NHS, very much independent contractors, much like GP colleagues, dental colleagues as well. But I think very much kind of seen by the public as delivering a lot of that. There's maybe a slight difference for us in that community pharmacy having that kind of open door, and still trying to divorce ourselves as much as we can from that kind of retail aspect and moving into service delivery, because frankly over 90% of the work that we do is for the NHS. All those teams that are out there, so every team has got a pharmacist, more than one in some cases, and then a mix of pharmacy technicians and other pharmacy professional in their own right, and then support teams all with varied skills tailored to what that pharmacy is actually trying to do for its community. An increasing thing that we're seeing now through our funding of training places and of a service to actually use the qualification is that we've got a lot more independent prescribing pharmacists out in the network now. We have just of our last month's data coming in, which would have been, this is June, so that would have been May, so round about end of March, at that point we had 28% of pharmacies with active independent prescribers in them, which is fantastic, and at the moment they are dealing with acute common clinical conditions, so very much the pharmacy first that you'll all kind of know and hopefully have used and know well. They are providing an enhanced service there, but having those IPs in these pharmacies unlocks a whole potential for what they could do in other areas, such as what we're talking about today in terms of substance use. We've already gone over national services that are delivered, so we've got medicine supply, pharmacy first, and then our local services. And we've probably had a wee bit of a chuckle here at the bottom, and including, so we've got across the country, I counted at least 4, I'm sure there are more different ways of saying support for people who have substance use issues, and there's MAT, OST, ORT, SMS, and the list goes on, and that probably gives you a wee bit of the flavour of that. One of the things I'm going to be raising in a couple of slides' time is around about variability and how we try and move away from that wherever possible, because we're quite a small country. So next slide, please, Kyle. So again, some of this has already been gone over, but I think just to kind of emphasise our key strengths, so accessibility, open door is really always has been the thing around community pharmacy that sets us apart from others. Now, open door doesn't necessarily mean you won't wait a little bit, but the open door is there. And I've seen the question in the chat, and I think actually open door, does that always mean welcoming to everybody? People are telling us perhaps not, and that's something we need to face into, and in the Q&A I'm sure we'll face into that. But what we've got as well is we've got a huge body of evidence, academic and otherwise, that tells us that what community pharmacy teams are fantastic at, they absolutely excel at, is building relationships over time, and with those relationships come trust and confidence. People open up to us in ways that they don't with others, and actually just that popping in to see people is very much valued in the community. And the pharmacy team as well, really, because they build these relationships, can very quickly and effectively pick up on something has changed here, something is not quite right, this person is not presenting as normal, and that goes for the entire community that they serve. And there's real value in that they probably can't put a number on, to be fair. And I think it's fair to say as well, over my time both working full-time in community pharmacy and in this role in CPS, I think it would be fair to say that what pharmacy teams are really good at, they're generalists, they're expert generalists effectively. What they are particularly good at is opportunistic, short, sharp but effective interventions with patients, whether that is public health promoting, whether it is responding to symptoms, whether it is picking up and supporting people to get the very best out of their medicines and minimise the harm from their medicines. That's the space that they operate in the best. Not necessarily sit down for 10, 15, 20 minutes, half an hour. That's where actually delivering something that requires that in the community pharmacy setting whilst running all the other services becomes a little tricky, but actually these short, sharp, really clinical interventions are their real strength. Challenges though, because we always have to cover these as well, it would be unrealistic and a bit disingenuous if it didn't, is demand. So I think again the guys covered really well that everybody's busy, absolutely everybody in the world, we're no different there, but I think in particular due to coming out the other side of the pandemic, I think if folk that didn't already know that community pharmacy had a lot to offer really became aware, because we were effectively one of the few places open right throughout in that very visible, physically open way. All services did continue to run otherwise. I think what we've seen since then is where my role in particular has shifted a lot from, I think, running around trying to convince people, here's what we could do, here's what we could do, do you want to try this, do you want to try that? Actually, there's now almost a flood coming towards community pharmacy of, could you just do this, could you just do that? I've got a fantastic idea, which is wonderful. And I think our answer is evolving into, well, actually, capability wise, absolutely, there's a number of things that could be done, but what we need to look at is priority and capacity and what can be done there, and actually resourcing too. And that's no different from any other area of practice. Next slide, please, Kyle. Thank you. So local work, I said to talk about this. So when it comes down to what we're actually talking about today in terms of support for people with substance use issues, Chris has already covered that these are locally commissioned services. The way that these are actually set up is just like Community Pharmacy Scotland is made up of pharmacy owners who've been elected in place to speak on at a national level on behalf of the entire network. Part of our structure also includes local committees called Community Pharmacy brackets Health Board committees, and those again are elected representatives of the local group of community pharmacy contractors who've got the mandate from their constituent members to go and speak with the NHS and put in place local services to meet the needs of patients and look at actually all the terms of those and indeed the funding package around about it. So as an example there, Chris is working in NHS Lanarkshire, and he'll work directly along with his colleague Lauren with our Community Pharmacy Lanarkshire Committee, led by our chair and vice chair that represent owners. It's fair to say that services are varied, wide across the country. You get some boards with loads of local services, some less so, but what is true across all of them is that support to deliver MAT standards dwarfs absolutely everything else. It is the big ticket item locally in terms of both the effort and time that's spent in community pharmacy delivering those services for good effort, and actually the money that the NHS spends on commissioning community pharmacies to do that work, which is grand. Now, in an ideal world, and for those of you that are commissioners, you know fine well, what we'd love to do is start with, okay, what practically does this cohort of patients need? Let's design a service to meet that need. Let's run it through that filter of what can community pharmacy actually do for you in this space, and then look actually at how do you calculate what that costs to deliver. And of course, it's a business, so businesses require a fair return. Build that in. Bob's your uncle. You've got a package, commission the service. That's not how real life works. How real life works is we've got budgets to work within, and that often stuffs up the ideal process. But we work very closely with our NHS colleagues to get to a place that delivers the very best we can for the people we're trying to support. Next slide, please, Kyle. So how do we move forward given that? So I think right out the bat, what I would say is that the CPS, or the national position, we've had this at our board twice in the last 2 sort of 3-year term periods, just to reaffirm that actually, if it were possible, then the CPS position would be that actually we would love a national solution. We are a reasonably small country. There are individual communities that need slightly different support because of their geography, but by and large, the people need largely the same support, and it would be ideal to have that standardised for a number of reasons. We'd all like a Once for Scotland approach. I think the diagrams that have been shown earlier in Chris's presentation show that we're quite some way away from there. But if there was something that could kind of pull that all together, then we would be on board for those discussions. It's the best thing for the patients and the best thing for the pharmacy teams trying to deliver the services as well. But we're not there yet. But what we have got is a great move. The last kind of 5, 6, 7 years, we've moved in most health boards really away from a kind of sad transactional setup where it was very, very focused on that dispensing and supervision of OST. And that was kind of it. There were loose arrangements around about how you looked after the person as you did that. But really, this move towards a package of care that's built around about the person that goes so much wider than supply and supports harm reduction. It's really, really wonderful to see. Not totally complete yet, and we've got probably some variation between those. Really, at its core, we've got harm reduction advice for the whole population. We've got that supervision. We've still got the dispensing part in there as well, because that is important. But the really important bit is that formalised, structured, contractualised feedback loop. If X happens, this person needs informed. If the patient is telling you this, or the person is telling you this, then here is how you support them. And it's led to some really wonderful stuff and some raising the bar of the standard in community pharmacy as to what's delivered. I'd say there was, to give our members their credit as well, there's a whole load more gets delivered that doesn't get seen, and would be lovely to kind of bring into the package. Some of the newer stuff that's happening as well, so we have absolutely got our ear to the ground of the changing patterns of prescribing and what people need, and some of these novel delivery methods that are really good, and we've got in and about that and had a look at actually locally getting engaged in pilots for Buvidal administration right in the community pharmacy setting, because that accessibility really supports people and supports boards not to necessarily have to have that machine in place to cover the administration for people who are prescribed Buvidal. And from the ones that we've had so far that have been running for a while, I think everybody involved, it's just big thumbs up all round. So really keeping an eye on that and encouraging growth there. Kyle, next slide, please. A couple of the challenges though that we do have that we need to work our way through, which we will do with our colleagues, is the service specifications that we've got out there into the package of care that I said earlier, they can vary. They're a wee bit concertina. You've got some that are really sort of clear, concise, say exactly what they need to do. Others that do that, but there's a huge volume of stuff in it. I think we need to remember the context the community pharmacy teams are working in is that they are delivering all these local and national services and want to do their absolute best. But if you open something up to say, right, what should I be doing for this cohort of patients, and it's 10 pages long, that gets challenging to make sure you're meeting absolutely everything all the time. So that can be a struggle, particularly where some of the sort of instruction or the intent can sometimes be a little vague, but we absolutely work with our colleagues on moving that forward, and we've had great progress. Technology, again, varied. I'll not linger on this, but that really can hold things up and also affects the kind of trust of, oh, if I put this piece of information in here, is somebody going to see it? Do I need to lift the phone as well? Moving to a place where we've got really robust technology would bring us on leaps and bounds. And what I probably haven't mentioned today as well is we've got a kind of moving population of pharmacists and pharmacy support team workers and pharmacy technicians as well. And dead easy in Scotland, as I say, a small country, to kind of cross borders. And this can be a real problem where you're trying your best for your patients, but actually across a week you could be working easily in 3-4 different health boards, understanding not just the service specification of what you've got to deliver, but then also the technology you've got to use can be a real challenge.
Adam, it's just to say you said you would need a prompt, and if you can come to the end, that'd be great. Thank you.
Okay, you're absolutely right. So running through the rest, yeah, we need that resource to deliver. We need that kind of standardization, but we've got to work together with one another. And the stigma part, I think we'll pick up in the questions. So Kyle, yeah, just move on the next two would be great. Skip over the end when I meant to start. The next one again. And again, yeah, this is just to illustrate we need those relationships in place, because that's all that opens up on the path all the way to results for these patients. We're all trying to look after the same people. Next slide again, Kyle. Yeah, do this. So I'm a practical guy. What I'll leave you with is, what should I actually do next? If I'm in a position of any sort of influence, what do I want to do? I would say direct engagement with your local CPHB contractors committee if you don't already have it, as well as speaking to your NHS board leads. That's the real voice of contractors there. If you can, we were happy to facilitate time out in pharmacies to understand those issues, the training, skills gaps, services that are working with. Consider seriously a national solution. And actually the real big one would be what you're asking pharmacies to do. Have a really, really close look, clarify exactly what you need to do, distill it down, boil it down. You've got a much better chance of it getting delivered consistently. And finally, elephant in the room. We all know that these things need to be resourced well to make sure that they're delivered well. And I've completely failed in my promise to keep this to time. Apologies for that, Claire, but thank you very much for bringing that to my attention, and I will now whoosh.
Not at all, and there's so much, and I fully appreciate there's so much more you could have said as well. So thank you ever so much for taking us through such a lot of detail in quite a short amount of time. So thank you, Adam. We will shortly move to questions, and a really important topic on stigma has already been raised in the chat, and we'll come to that. But before we do that, the reason I was asked to chair today is not because of my previous roles in pharmacy, although it's very lovely to see so many familiar faces. But it's actually so I could just speak for this point just for a few minutes about how today's session fits with our wider work in Healthcare Improvement Scotland on community engagement, which is part of my remit. So Adrian highlighted that successful delivery of MAT standards can only be achieved by involving people with lived experience. Tony picked up on this as well. And this is really the topic that I wanted to pick up now. It's really what drives me is the focus of our directorate in putting the people at the centre of change. So I think, let's be clear on this, like, none of us go to work every day with the aim of providing a poor service. And yet, while all of us might think we know how a patient or a service user experiences a service, none of us really knows what it feels like from their perspective. And that's where proper engagement with people makes a difference. It's really about understanding services on a whole different level. And engagement is really core to Healthcare Improvement Scotland's strategic priorities. So one of our priorities is around enabling the health and care system to place the voices and rights of people and communities at the heart of improvements to the safety and quality of care. And an important aspect of MAT standards and systems change is that successful delivery of any service change, which can only be achieved through that person-centred and people-led improvement approach. All NHS boards, all IJBs have a statutory duty to involve people in the planning and development of services, and that includes both service change and service cuts. And at HIS, we have a duty to support, ensure and monitor that boards achieve this. And one of the key documents to read on this is Planning with People. So that's a joint publication by Scottish Government and COSLA. It was updated just last month, and it sets out community engagement and participation responsibilities. It applies not just to health and care boards, but also to independent contractors, including community pharmacies and GP practices as well. And Planning with People describes each step of good engagement practice and how engagement is assured. So we produce loads of resources to help people achieve good engagement practice and to meet those expectations of Planning with People. So for example, we've got a How to Engage framework, which sets out the core steps of planning engagement. We have a participation toolkit, which provides a range of tools and resources for planning engagement. We've also got resources to support service change. We've got a quality framework for community engagement. In short, lots and lots of things that's available, and we can pop a link into the chat so that you've got access to those resources. But I think we're very much going to come back to stigma in the Q&A in just a second, and I think this is a topic that we've known for some time that we need to address in pharmacy. So the Royal Pharmaceutical Society's paper on pharmacy's roles in health inequalities quotes a patient who said she felt her pharmacist saw her as nothing more than her script. And reducing stigma has benefits not just for the individual, but also for the health and care system as well, because it encourages people to access services earlier. And this all comes back to engagement again. So if we engage with people, we're going to better understand what those barriers that people face are when they try to access services. And therefore, from that, we will understand how to reduce that stigma that so many people face. So in summary, I think engaging with people and communities results in better understanding for decision making, so the practicalities of how a service might work for people. It results in improved relationships between the public and a service, so people feeling ownership of that service. It definitely results in higher quality, more person-centred services, and ultimately all of that means improved health and well-being. So I hope if you weren't already convinced about the value of engagement, that has given you a bit of a taster. I cut it short for the interests of time, so that we would have time to move on to our Q&A section. And so I think we've got just about 10 minutes to take some questions from you all. So it'd be great if perhaps all four of our speakers could come on camera. And I think we're going to kick off with a question from the chat box earlier from Mark in NHS Dumfries and Galloway. And he asked, what time frame do you think it will take to get a national service? And perhaps that's a question I can ask Adam first of all.
We don't have one. We would love to. Those moving parts and the part that Chris kind of showed up, that diagram shows you all the different players. We've also got, we would need to change regulation and legislation that currently says this is specifically a devolved down to local service. We also then need to unpick, so it's been however many years that community pharmacy has been supporting people with substance use issues, so we need to unpick all of those commissioning routes and funding streams and all the rest of it, and bring it together. But where we can start and what we can say, that sounds like I'm just throwing up the barriers here, but actually there's already been some really good work started. So Adrian and the SPISMs guys have worked in it, and I've kind of thrown in a wee bit of comment now and again around about, okay, what would be the ideal kind of package care or approach indeed. So for all that, we may not get an actual commissioned, this is the national service across Scotland like you would for Pharmacy First anytime soon, if I'm being blunt and honest. We can, by working together and keeping those national and local things rolling at the same time, we can move much closer to that by creating consensus and moving forward, and that'll happen a lot quicker, and we're already on that journey. So I'm going to, like a politician, not actually answer your question there, Mark, other than far away.
Thanks very much, Adam. Do any other speakers want to come in on that? I don't see anyone talking or hands raised. So in which case, can we go to the next question, which has already stimulated quite a lot of chat in in the box, which was from Sarah McLeod, and it was about how can stigma be addressed in community pharmacy. So Adrian, perhaps if I could come to you first, and then to Tony, who's also commented already in the chat. So over to you, Adrian.
Yeah, so Tony and I have both commented from a pharmacy perspective, just from a general population perspective. So National Stigma Action Plan was part of the Drug Death Task Force Changing Life recommendation. Couple of things that the Scottish Government have done, the See Me campaign, which was a bit broader around mental health stigma and discrimination, and that's ongoing. And if people are not familiar with that, I would encourage you to take a look at that. There was, at the end of 2021, a national campaign around tackling the stigma of addiction. I think that it's going to require a bit of a drip feed response. It's a cultural change. And if you want just coming back to a pharmacy example as a case study that is published on Buckenhaven Pharmacy that we did around that I had the pleasure of visiting at the beginning of 2023, that really does have that culture, and I'm going to use a strapline of a member of staff is treat every patient as though they were a member of your family. And if everybody did that, we wouldn't go far wrong. So
That's
over
great.
to Tony, if you wanted to answer and add anything.
Yeah, so I think there's already really good work out there already. I don't think we should go and reinvent the wheel, but I think what we need to not do is make it too complex. That underpinning anything you go to change based on somebody's experience of stigma is probably starting with a conversation. Healthcare Improvement Scotland have got really good quality improvement tools that can support pharmacy teams to do this. There's the Care Experience Improvement model, and I know I've just said please don't make this more complicated, and there's another abbreviation to learn, but it's a really simple framework for having a conversation with service users and people to understand the stigma they may face. I think for pharmacies, there's maybe a hidden part of stigma of how we've organised our services. There's a fantastic paper done by Tayside on service user experience of, I think is it called Standing Outside the Junkie Door, which is incredibly stigmatising the language, but it's really useful to see that that paper is put together based on a qualitative research piece of work done by Public Health Pharmacy Input and Tayside. I think it was Andrew Radley that was one of the report authors. So we already have good data and good information out there, but it's maybe just asking ourselves across our systems, are we consistently asking people about their experience, and are we using that experience to then inform policy processes, physical environment and space? Do we feel that our teams out there have enough experience of doing this? Is there a barrier of this is too hard, too difficult to do? How can we lower that threshold to allow people to be as autonomous as possible in their areas of practice, to go and seek that experience and change the way they're working, to make it feel and experience better for people with substance misuse. So hopefully that's helped answer that. It's really difficult though, Sarah. It's very easy to say that out loud, more difficult to realise across the system.
Yeah, thank you both, and it's a really powerful report, the one from Tayside, and I think Adrian's just popped the link to that into the chat. I think the final group of questions, unless anyone else wants to raise a hand, I think we've got 2 minutes left for questions. Unless anyone wants to raise a hand, I think the other topic that really came through in the chat is around Buvidal pilots. And I don't know, Adam, if you want to kick that off in terms of information for people.
Yeah, sure. So we've got, and there's people on the call that are much closer to it than I am, but to my knowledge, there's Dumfries and Galloway, Lothian, smaller scale. I think Grampian's probably the furthest ahead. And I know that Ayrshire and Arran are kind of moving forward, and there's some GG&C activity as well. So it's really kind of ramping up. And I think really I think everybody here will be familiar with the benefits for the patient in general of shifting on to Buvidal if it suits their life. But in terms of the community pharmacy administration, what we're hearing back is that actually it's a different type of work. It's maybe more involved there and then, but opens up more of a space, less about the practical stuff, but more of a space for an actual in-depth conversation, because it takes that little bit longer. So there's a real sort of halo benefit of the teams doing that, which I think will help with what was an initial concern of mine and some of my colleagues around, if we move to this and there's much less contact, how then do you keep that eye on that person, notice that change, make those interventions that we're being asked to do and that we've learned to do over these years, but actually having those less frequent but more in-depth conversations with these people, we're at least hearing back initially, is of real value. And I think the bottom line is this is absolutely 100% doable in community pharmacy. It just needs the investment in the space, the right skills, and all the rest of it in place. But yeah, I think everybody's given thumbs up just now.
Great. Thank you ever so much. And I'm afraid at 12:28, that means we've reached the end of the time for Q&A. So a huge thank you, first of all, to all of our speakers today for their really informative presentations. Thank you to everyone for joining us today and participating in the session. We will be in touch to share the slides and a summary of the discussions, including links to resources and reports that have been mentioned. Our next webinar will be on the 3rd of September from 11 to 12:30. More details will be sent out in the near future. And just before you leave, in this final minute that we have, we would be really grateful if you could complete the final poll questions, which are on the screen just now, about today's session, which will help us develop and refine our future sessions. So while you're doing that, please do connect with us on X, which I still call Twitter, which is at HISMAT, and also by email. The email is in the chat box from earlier, but his.mat@nhs.scot. And finally, just to say a final thank you to everybody, both our speakers and all of you who are participating, for your time today, and to wish you a very good rest of the day. Thank you so much.